Hello, my name is Emily Lichtenberger, and tonight I will be going over things that I have learned in my final healthcare management class that's going to get me to my bachelor's in healthcare administration degree. This presentation is on the importance of having leadership skills, thinking, and management as it pertains to critical access designation. So for tonight's agenda, I am going to be giving a high-level overview of what it means to be a critical access designated hospital. I'm going to review the dynamic culture leadership model, the strategy that I have for the model, advise on key stakeholders that need to be presented with the facts and information from the beginning to the middle to the end, review the buy-in strategy that I feel is best, review the efficiency and effectiveness measures, and finish with the importance of process, motivation, interpersonal relationships, and communication as it pertains to quality, service, finance, and culture metrics. So what is critical access and what is the importance of it when it comes to hospitals and ensuring that they have the designation appropriate? So designation is given to eligible rural hospitals by the Centers for Medicare and Medicaid Services, which is CMS. You'll see this quite a bit in this PowerPoint, CMS. So this type of access and designation is regulated by CMS. It has a 101% reimbursement rate, and all hospital departments are within 270 yards of the hospital. So rural hospitals are the type of hospitals that are currently going for critical access. They're doing so because rural hospitals do not get all the funding, do not get the patients, are not able to serve their communities like they should, like inner city hospitals. So say, right now our hospitals in Van Wert are affiliated hospitals in Columbus, and we do not serve the same type of socioeconomic citizens. So this was designed to reduce the financial vulnerability and improve access to care. Financial vulnerability stems from that 101% reimbursement rate for Medicare patients. So any patient that walks through our hospital doors or goes into an outpatient hospital department, we have the opportunity to gain more reimbursement from the insurance, which is Medicare, than we would if we were not critical access. So my problem statement for this presentation tonight is why is critical access so important to our rural communities? And it's to ensure the long-term financial sustainability of rural healthcare by improving Medicare reimbursement, preserving local access to care, and supporting future service expansion for the community. We serve over here in Van Wert County, we serve a large population of geriatric patients who do have that Medicare. And so we have to be able to critique or to bring on service lines that are going to support them so they do not have to travel 45 minutes away to another facility east or west of our destination. So next I'm going to introduce the leadership model that I chose for critical access hospital designation. That is the dynamic culture leadership, or the DCL model. So within this type of model, it is intended to fit within the situational and transformational leadership paradigm with an emphasis on organizational culture development. When our hospital decided to become a critical access hospital and put in our application and go through all the phases of what it means to be a CAH hospital, we knew that it was going to be pertinent that our managers knew the why behind the culture and why we were doing this, because we have a current state in healthcare and we have to make it to some type of future state, especially if we want to be sustainable. There are 3 levels to this leadership model. There's personal, team, and organizational, and we'll review that over the next few slides. This type of model also provides both a descriptive and a high-level perceptive process model of leadership. It is goal driven and is not to be completed by yourself. It is meant to be a model that helps you develop your team and your organization as a whole. So just like the DCL model, becoming a critical access hospital requires personal, team, and organizational leadership involvement. It requires interdepartmental collaboration. You've got quality facilities, your C-suite executives, outpatient stakeholders, and inpatient department managers all working together as one for one future goal. It is crucial for these team members to bring multiple aspects of knowledge and a wide range of skills, abilities, perspectives, and backgrounds. You don't want one person to just do everything because you're going to miss something. It's just how it is. And then, as stated in our book by Marianne, you want to guide and direct culture through communication improvement, organization-wide strategic planning, decision-making alignment, employee assessment and empowerment, and knowledge management and organizational leadership when it comes to the dynamic culture leadership. Overcoming past habits, ideas, and tendencies is crucial within this model. We're not in healthcare, we can't be stagnant because healthcare changes so much. So we have to not just conform to the change, but we have to adapt to the change. We have to be the change in a positive light. And this model directly reflects that. So to kind of piggyback and keep going on our DCL model, this is the model that I chose for my critical access designated hospital designation leadership management continuum. So first we start out with what our core is, which is science of leadership and future financial sustainability. That's why we're going for the CAH designated hospital. So you start with your number 2, communication transparency. That involves communicating the why behind policies and requirements, gathering necessary staff to ensure Joint Commission readiness, and following through when application is accepted, when the Joint Commission window opens, and what action plans need put into place, and then follow up with the outcome. We then move to strategic planning. This is a huge one. I love strategic planning because sometimes you don't always get it right, but you work through who all needs to be involved in the planning process. So you gather the necessary stakeholders to hold mock surveys, to review and do tracers within the clinics, ensuring staff and managers are prepped for the survey. You decrease your bed capacity from 29 to 25. You ensure inpatient stays are less than 96 hours. Both of those things, decreasing the bed capacity and ensuring inpatient stays are less than a certain number of hours, is part of the CMS guidelines to being a critical access hospital. And then with this one, you ensure legal and outside consulting agencies are involved to make sure hospital, inpatient and outpatient departments are prepped and ready with next and future steps. The decision-making alignment, so you grab your C-suite executives, they're aligned and on board with CAH designation before they even bring it to the managers. You ensure financial sustainability. What does our current state look like versus our future state? And you gather management alignment thereafter, and then it goes down the totem pole all the way to your frontline associates. You then have your employee enhancement. Oh, I need to back up. You then have your decision-making alignment. Oh, we just did that one. So your employee enhancement, sorry about that. You celebrate your wins. You gather the proper team members for the issues that arise and encourage continuous teamwork and collaboration and learning. We are all in this together, so it's best to lead with a glass half full kind of mentality versus a glass half empty kind of mentality. You then have your knowledge management. You ensure managers know the why and are able to speak to the CMS guidelines behind critical access hospital designation to their staff and their frontline employees, and how to positively impact the hospital organization and the community. Once you're given that critical access designation, you evaluate the outcome. You work through the barriers. You explain different issues that arise, whether that's when Joint Commission comes or after you become a critical access hospital. One barrier that I'd like to just give an example of for this type of leadership management model is we realized when we were becoming a critical access hospital that our imaging and MRI, so our x-ray and MRI machines, were more than 250 yards away from the hospital. They were across town at what we call our walk-in and primary care offices. We had to quickly activate a team, pull together sidebar conversations, and make sure that our north building was moved. We're not losing a service line, we're moving a service line, but that x-ray and MRI was moved back to the hospital. So we were within those regulations, because if we bill more than 250 yards away from the hospital, we could then lose our critical access hospital designation. So that's just one of the things where, we weren't notified when Joint Commission came in, but when we had our consulting person come in and talk to us, this is one thing that we found. So we evaluate the outcome. You reflect. You look at what the current state is versus the future state. Where do we see ourselves making the most impact within our community? What services do we want to be able to provide in the future? And all those things. You want to look at it as a future state. You then revamp. You continuously be Joint Commission ready. You tweak future workflows. You determine construction if it needs done or what services you're bringing on. And you pull in necessary service line leadership to help revamp the Van Wert healthcare model. And that can be a consulting company. That can be a Joint Commission. That can be quality. That can be anybody that you use to help revamp what needs fixed in the future. There are 3 things that I think are crucial when it comes to model adoption within the staff members, the management team, any of that. So you've got your clear communication, strategic planning, and decision-making alignment. So if there's one thing that I've learned about being a leader, is that staff members enjoy when their manager gives them clear direction, communicates, is transparent, and includes the why behind the implementations that are coming. The why is extremely important with this, and the why goes along with all 3 of these model adaptations. Clear communication, you're explaining the why, you're being transparent with them, you're telling them why the decision was made, and you're helping them understand the why behind the strategic planning and why they weren't included in the beginning in the first place. I also believe that including the proper stakeholders from the get-go is pertinent in the succession plan. When the organization I currently work for decided to go for the CAH designation, the C-suite spoke about it amongst themselves and then shared it with the managers. After that, they provided a timeline to the managers and kept us all in the loop when our application was approved. They then brought in the quality and safety team to ensure everyone was prepped for the Joint Commission survey. While model adoption can be difficult to gain buy-in, with transparency, clear communication, strategic planning, and the why, will help get employees on board with the changes that are coming and be able to adapt to the changes and not just conform to the changes. The key stakeholders for critical access designation that I feel are most important are these 5 right here. So you have your C-suite executives. I did not include those because they are the ones who make the most they make all of the decisions, and then they kind of tailor it down the totem pole. So key stakeholders that need to be involved when it comes to critical access hospital designation are your directors that lie under the C-suite executives, your managers, revenue cycle. They need to know what outpatient departments are going to be hospital departments. And that billing is going to change with this critical access designation. So they need to be made aware. You've got your providers and your APPs, and then you have your frontline employees. So as you go through the key stakeholders, another one that I think is important is your MARCOM team or your communications team. That team is going to be able to help guide conversations within the community, let the community know the changes that are happening and the designation that we get at the end of it, and how this is going to affect and be a positive outlook for our future state as an organization. So we've made it to our buy-in strategy. How are we going to get employees, managers, the community to buy into us becoming a critical access hospital. So you're first going to want to explain the why. You're going to want to be transparent with the why. It's not that we're in a financial hardship, it's that we want to be financially sustainable. We want to be able to have that access to care as we grow. We want to be able to bring on different specialties such as oncology that our current patients are having to drive more than 40 miles away to get care for. You've got your future financial sustainability. So you want to be transparent with them. You want to let them know that, yes, right now in the current state, we are financially sustainable. However, we want to be financially sustainable for years to come. You've got your rural community socioeconomic. So this deals with the ages, the race, the disabilities that you have within your community. And in a rural community, in my rural community, we are highly populated by geriatric patients. We have multiple nursing homes within our community. We have lots of baby boomers. You want to keep the generation in mind. You also want to keep disabilities in mind. How can we make sure that all of our outpatient offices in our hospital are equipped for, ADA, like they're up to par to get wheelchairs in? We have enough wheelchairs, the small, medium, and large wheelchairs. We are easily accessible no matter what barriers you have in life. Transportation is a huge one too. We have now a bus that goes from different counties to pick patients up for appointments or for surgeries and take them back home, depending on the surgery. And then you also want to explain, we have these needed services within our community. And so this is why we want to be critical access designated. We want to be able to provide these services such as oncology to our geriatric or even our younger population. Cancer is a huge topic in today's world. I personally have, my bonus son's mom has been traveling to and from Lima for stage 4 metastatic breast cancer. And I wish more than anything, we could serve her our hospital so she could stay close to home and not have to drive 45 minutes away to receive care. So the DCL model efficiencies and effectiveness that I think is pertinent to becoming a critical access hospital. We'll go through these here. So efficiencies, ER throughput, our wait time, our transfer out time, our, we track our, if a patient comes in with stroke symptoms, we track that throughput of the time they enter the door to the time they get to the CT scan to the time they get on, a flight to another hospital or are transferred to another hospital. We've got our staffing productivity. We currently keep a close eye on productivity because it's something that makes sure that we have enough staff for our providers. Length of stay. You want to make sure that when you're critical access designated, that length of stay has to be less than 96 hours. We also have an option to do a swing bed option as well, so they can have rehab and those sort of things with their stay. And then efficiencies, reimbursement rates. Increasing that reimbursement rate that you're getting will help lead you in a financial sustainability. Then you've got your effectiveness. So how are we going to measure these things? How are we going to make sure that we're doing everything appropriately with the efficiencies that we have over here? So first one is patient safety events, patient falls, patient, medication errors. We've then got quality measures. You've got your quality measures that you measure in the hospital and the outpatient setting. So you've got how are you able to equip your patients with what they need, your hypertensions, your chronic readmissions. What are we doing with those? You've got patient satisfaction scores. This is a huge one. Patient satisfaction scores, they're going to tell us so much. They're going to help us improve. Even if it's just the slightest bit, they're going to help us improve. And then you've got your Joint Commission compliance. You want to make sure you can still be accredited and make sure that everything that you have is what Joint Commission says is okay. So for this slide, I put in my 4-box review, which pertains quality, performance, finances, organizational change management. So you've got your patient safety, standardized protocol adherence, your monthly and quarterly tracers, which all goes under quality. You're going to do performance with throughput, utilization rate, your operational efficiency, your point of care testing, your workflows, your provider throughput when it comes to discharging, and then cohesive communication, making sure that everybody's on the same page when it comes to admitting, triaging, assessing, and discharging a patient. Your finances, so per our book, you're going to optimize financial, not per our book. This is from the CMS website. So you're going to optimize financial viability by 101% cost-based Medicare reimbursement. You're going to increase that and be financially sustainable as long as your cards are played right. And then you have organizational change management. You've got staff adaptability, transparent communication among leaders and frontline employees. You manage culture shifts, those who are on board with change and those who are not. You bridge gaps between outpatient providers, staff, and inpatient providers and staff. So I just want to take a moment to say thank you, Professor, for um, pushing us the past 6 weeks and helping us learn to the best of our ability. I have truly had a great time learning some new leadership skills over the last 6 weeks, and digging deeper into what I already know about being a leader. You helped push me to explain my examples on a deeper level, and you made sure that I was out of my comfort zone because I am really bad at that. So, thank you so much for all of your feedback and guidance over the last 6 weeks. I truly appreciate it.